On today's show, we're discussing changes in opioid prescribing over the past decade and how clinicians are balancing pain management with addiction potential. I'm Kate Schweitzer, Associate Managing Editor of JAMA Medical News. Staff writer Samantha Anderer is here to tell us about the news. Sammy, thanks for joining.
Thanks, Kate.
So it's been 10 years since the U.S. Centers for Disease Control and Prevention first issued opioid prescribing guidelines. How has their advice changed since then?
Right. So the CDC came out with its first opioid prescribing guidelines in 2016, at a time when clinicians and policymakers were trying to respond to the enormous harms associated with prescription opioids, which helped fuel the first wave of the U.S. overdose epidemic. The CDC's goal was to give primary care clinicians a framework for treating pain more cautiously. But although the recommendations were not intended to apply broadly to situations like cancer or post-surgical pain, they were often interpreted much more rigidly by states, insurers, and health systems. Experts told me that, in practice, the pendulum may have swung too far, with some patients facing very tight restrictions or losing access to medications that had been an appropriate part of their pain treatment. In 2022, the CDC acknowledged that the guidelines had, at times, been misapplied and updated them.
Got it. You reviewed 2 studies published in JAMA Network Open that looked into prescribing trends. What did the research find?
The studies paired nicely together, answering different questions about opioid prescribing to provide a fuller picture of the current situation. In one study, investigators looked at more than 110 million opioid prescription fills from 2010 through 2024, including nearly 15 million U.S. patients. They found that opioid prescribing declined substantially, including in specialties that historically prescribed a lot of these medications, such as orthopedic surgery, dentistry, and emergency medicine. Long-term prescribing had an especially sharp fall. One of the researchers, Molly Jeffrey at the Mayo Clinic, said the data suggests that overprescribing has been curbed, but that they also raise concerns about access for some patients. For instance, the study showed a shift in who is writing these prescriptions. Primary care clinicians now account for a smaller share, while pain medicine specialists account for more. If opioid prescriptions are increasingly concentrated among specialists, that can create barriers for patients in rural areas or for people on Medicaid, who may not have easy access to pain clinics but can see a primary care clinician.
And what did the second study show?
The other study investigated how patients use opioids for acute pain. The researchers included about 1,700 patients across 5 U.S. health systems who had been offered a short opioid prescription for acute pain in settings like emergency departments, primary care clinics, dental practices, or after cesarean delivery or knee replacement. What they found may be reassuring to clinicians. Most patients used opioids for only a short time. The median time to stopping was about 1 week, and most also used non-opioid medications like acetaminophen or ibuprofen. Patients typically used fewer pills than they were prescribed and had leftover medication. But the study also showed that about 1 in 10 patients were still using opioids after 3 months. The researchers emphasized that in general, the findings support current guideline recommendations for multimodal drug use and short duration of opioid prescriptions. Still, some patients may need to use the medications for longer.
I see. And so taken together, what do the studies suggest about the balance clinicians need to strike between caution and pain control?
Well, it's complicated. The experts I spoke with agreed that prescribing has become more careful, and that both clinicians and patients now have a better understanding that opioids should be used in smaller amounts and for shorter periods than they once were. But they also said that there's still real uncertainty about what the right level of prescribing actually is. Some patients may still have unresolved pain because prescription durations are too short or doses are too low. What's needed now is better evidence, particularly clinical trials examining opioids as part of broader multimodal pain strategies that also include non-opioid drugs and non-pharmacologic treatments. The overall sense was that the culture has shifted in the right direction, but that finding the right balance is still very much a work in progress.
Thanks, Sammy. All right, if you'd like to learn more, we'll include a link to Sammy's story in the show description. This week, we also published an interview addressing the clinical research highlights from the annual Alzheimer's Association International Conference. You can find that and all of our stories at jamamedicalnews.com. Thanks to Samantha Anderer for joining me. I'm Kate Schweitzer for JAMA Medical News. This episode was produced by Daniel Morrow at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening, and join us again next week.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.